All right. Hi, everyone, and welcome back to The Journey. So as you can see, today we're going to be talking about inflammatory bowel disease. And I know it sounds very similar to irritable bowel syndrome, but they're two different things, okay? One is called IBS. This is called IBD. All right, so this is consisting of two different types of diseases, Crohn's disease and ulcerative colitis. They have differences, but they also are very similar. So I'll do my best to try to point out the differences between the two so that way you guys can know exactly how to differentiate Crohn's to ulcerative colitis. But again, if you missed them the first time, feel free to always replay the video so that way you can see the differences, write them down, and know the differences between the two. All right? So first up, we're going to talk about Crohn's disease, also known as regional enteritis. And with that, it can occur in people of all ages, but mainly it targeted the group of 20s to 30 years old, okay? So within that time frame, that's when you kind of see the diagnosis is made. It can be a lot younger, but by the time they get the diagnosis and they figure out what's going on, they're within their 20s or 30s, okay? So what is Crohn's disease, right? It's an inflammatory disease that can cause anywhere along the GI tract from the mouth to the anus, right? But mostly occurs by the terminal ileum, which is pretty much on your right side. It's the very ending of the small intestine going into the right. So with Crohn's disease, you're mostly going to see it on your right. That's very important because with ulcerative colitis, you mostly see it on your left. Okay? So again, I point them out. Crohn's can happen anywhere along the GI tract, but it only happen there. Ulcerative colitis, it just happens in this area. Okay? Within the colon area. All right? So with that being said, it leads to a thickening and scarring of the mucosa, right? And it's a narrow lumen, and the reason why it's a narrow lumen is because of advanced thickening of the bowels, and they become very fiber optic type, okay? And with that, you can also have ficistulas, ulcerations, and abscess. And the abscess is formed because of inflammation that extends to the peritoneum, all right? This disease process can go into remission and exacerbation. And remission means it's at rest, so that means all of a sudden it just goes away. It's completely fine, but then it comes back. And when it comes back, the word aspiration means to come back worse. So it never comes back exactly the same. It comes back a little bit worse. All right. So the appearance is cobblestone. All right. So if you ever back in the days, right, with the horses and the chariots and things like that, they had the cobblestone or so. So if you can think of those stones in different patterns and zigzags and everything, that's the appearance that you're going to see with a person who has Crohn's disease. All right, and all layers of the intestines could be involved. And what you'll see with it occurring, you'll see the disease part, then it'll be normal, then the disease part again, then it'll be normal. So it doesn't always happen throughout the GI tract. There's areas in the GI tract that's completely normal, but then there's other parts that is attached to that same area that has a disease. So that's why I said it comes in patches, okay? So it doesn't all come at once, but it comes in patches, okay? So there's the bowels can be separated in different sections where you have the disease section and then you have the normal section and the disease section. So here I drew an example here so you can see, right? Let's say this is my bowels, this is the disease, then all of a sudden here, this is completely normal, then I have the disease again, then it's completely normal, then I have the disease again. All right, so it appears and goes, right? When it's at remission, it's gone, right? But then when it comes back and it's exacerbated, it's coming back worse. So let's say now it takes up this whole area, right? So again, remission and exacerbation. So with this, the diseased bowel loops sometimes can adhere to other loops around us that's surrounding them. Okay, so this would be more like when you have the small intestines, right? Because it wraps around, you'll see them pretty much adhering to. So sometimes they can be almost like connected in a way. All right, so this is what your Crohn's disease is about, and the main things that's going to be different is it can happen anywhere in the GI tract. 20 to 30 years is when you're going to see these patients mostly affected by this, right? It happens more on the right side, right? It's cobblestone appearance, okay? It's going to be in remission and an exacerbation. The cause of Crohn's disease is unknown, but genetic factors does play a part most of the time when they do diagnose a person who has Crohn's disease, whether a sibling or someone else has already had Crohn's. So genetic factor can always play a role in the cause of why it's occurring. Also, we have your clinical manifestations, which we know is your signs and symptoms, which is also known as your nursing assessment. So these are the things that you're going to see: scar tissue formation, formation of granulomas. It happens in 50% of the cases, okay, and a decrease in lumen. All right, so everything that I have in purple, again, is mainly what stands out for Crohn's disease. Everything else is what they kind of share in common, what you will see is similar to the signs and symptoms for ulcerative colitis, okay? You're going to have abdominal tenderness and spasms. You may have distension, okay? Then you are going to see anemia, right? Because they may have bleeding or some sort. Steatoria, which steatoria is pretty much fat in the stool, and it's going to give a very, very small odor, all right? And the stool is going to float in the toilet, okay? Because again, fat is less density, so it rises to the surface, okay? So with these people who have stool, it's going to float, okay? You're gonna have a very foul stench, and it's pretty much fat in the stool, okay? And with that, it's because people who have Crohn's, they have problems with absorbing the foods properly, and one of the things that they're not able to absorb properly is the fat. So you'll see the fat kind of go out within the stool, okay? You're going to see abdominal cramping after meals, okay? And it's going to be a cramp-like colicking type of pain, all right? You have chronic diarrhea. It can be semi-solid, and it may contain mucus or pus within the actual stool itself, okay? Again, weight loss, dehydration, electrolyte imbalances, fever, and leukocytosis, and then you may have malnutrition, which you may see more of a malnutrition within Crohn's than in ulcerative colitis. Doesn't mean that you're not going to see a malnutrition with ulcerative colitis, but you're going to see a worsening of that within Crohn's disease. Now we have the complications of Crohn's disease. So with the complications, we have intestinal obstruction, which again, we have like those cobblestones, almost look like little bulbs or so within the GI tract. So imagine if you was to have a multiple of those bulbs, right? It blocks the passage. So just show you just a little example here. Okay, actually, I'm going to put it down here. Okay, and then I'm just going to grab my marker, right? So I have these bulges here, 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 right? All right. So now I have my stool, and my stool is trying to pass, or it could be food, right? So it could be food or stool, depending on where it's happening in the GI tract, right? If it's happening in the upper part of the small intestines or the lower part of the small intestines when it's passing, and now we're going into the large intestines, okay? So whether it's the large or the small, right? I have a passage here. It blocks it from having it going through rather than if it was to be clear. If it's clear, I have stool that can come up here in this area, stool that can come down here in this area, right? I have all this space to work with. When I have the Crohn's disease, right, and I have this intestinal obstruction, I don't have all that space to work with. All I have is just this narrow area here. And then maybe I have a little bit more space to work here. And then once the disease come back again, because they come in patches, right? Let's say I have some here. Then I'm back at narrow again, okay? Whereas here I have all this space to work with in a regular functioning one. So if it's happening in the small intestines, I'm going to have problems with malabsorption, right? Because I have malabsorption here. I'm going to have problem with malabsorption because all these little things, right, attached in the small intestines has villi, and all those areas are able to absorb and take up all that nutrients that the body needs. If I have these cobblestones that are blocking, right, this whole area don't get to be absorbed properly just because it's a blockage, right? They may be absorbed here, right, but they don't get to be fully absorbed. And then let's say, right, those cobblestones starts building up, building up, building up, building up. Now I have what? An obstruction. So my stool or my food, depending on where it's happening, can't pass through because of the obstruction that's occurring because of all of those cobblestones are all piled up. So eventually now I have nothing. All right, so that's what they mean when they say as a complication. So that's as it gets worse and worse and worse and the disease progresses, eventually it blocks off that area and there's an obstruction, okay? Also, you have stricter formation, and that's pretty much the abnormal narrowing of the passage, right, which I just demonstrated here. You have a narrowing that's happening, that's occurring, right, because now it's no longer just a free passageway. I have things that are interfering into that passageway, so it's narrowing that space. And as the tissue scars itself, right, all of us, like same thing when we get a cut, right, eventually we get a scar. And that scar tissue builds up. And, you know, if you used to open up a scar continuously, that scar is not going to look the same when it initially happened the first time. It's going to be such a thickening on there. Sometimes you may have a keloid or so, right? And it's a thickening of that scar that eventually it raises above. And that can also cause an obstruction as well, so, or a narrowing, because eventually it thickens that wall. Okay, so think of it as if you was to have a keloid type of skin, right? Or I constantly tear something, it heals. I tear it again, it heals. I tear it again, it heals. Eventually, it's almost like as if you're stacking paper on top of each other until that stack of paper gets thick. Okay, and if I have this passageway to work with, and I have a thickening that's occurring here, right? I have a thickening. Sorry, let me use the black because this is still the intestinal wall. I have a thickening that's occurring here, okay? And I have the thickening that's occurring on this side, right? Isn't that passageway a lot smaller to work with? Okay, so that's what they mean when they say you have stricter formation that's going to cause the narrowing, okay? Also, you have perianal disease. Malnutrition, which I already explained here why you will have the malnutrition, right? Fistula formations, right? And with the fistulas formation, you are always going to be prone for infection. And you may say, what is a fistula? A fistula is pretty much a crack, right? Torn in between whichever lining, whether it could be the colon, whether it's the small intestine, there's a crack. And whenever there is a crack, right, what can get in those cracks? Bacteria, things that don't really belong, stool, in those areas, right? If it's happening in the colon, there's a crack, stool can get into that area instead of it being flushed out properly. Things settle down in that area, it gets inflamed. Infection or bacteria, right, can go down in those cracks, and eventually now I have an infection, okay? So fistula formation can definitely be formed, and it's pretty much, like I said, those tears, right? And then you have fluid and electrolyte imbalances. And again, you can have fluid and electrolyte imbalances because you're not able to absorb the food properly, right? Or different areas within the colon or so that reabsorb fluid and things like that are not able to reabsorb them because you're constantly having a diarrhea. So that's fluid that you're losing from your body. And if you're not putting those fluids back in, you lose them, you become dehydrated, and you become you have the imbalances of your fluid and your electrolyte, okay? You also have abscess formation, right, which eventually is going to cause internal fistulas, which pretty much is going to either have a fluid accumulation within that area, because remember, it's a crack, a tear, right? So you have stuff that collects in that area that should not be collected in that area, because if it was once sealed, right, nothing will be able to penetrate and go in. But because there's a crack, things can now fall in. And when they do fall in, you can have a fluid accumulation, and you invite yourself up for infection, all right? And then finally, last but not least, you increase the risk of colon cancer, right? Because you have all these problems going on with your GI tract. Your body is constantly trying to repair itself, right, from the inflammation and things like that. You have to go through the process of mitosis. Those cells are going to be abnormal. When they are abnormal, right, and they continue to multiply and multiply and multiply, and do things out of the norm, right? You have your cancer cells, and this puts you at a higher risk of having colon cancer, all right? So you can kind of see here, I drew an illustration so you guys can kind of get that concept of exactly what's going on with Crohn's disease, okay? So it can happen anywhere in the intestines, okay, or anywhere within the GI tract. So it can be on the esophagus, right? And if you have these lumps on the esophagus, you're not able to chew your food. You may not want to eat because it may be painful, right? There's a lot of things that are going wrong. It can be in the stomach that you have all of these areas, right? And the food are not able to be broken down properly because, there's a blockage of some sort. Or the area where the pyloric is, right? That sphincter that opens up from the stomach to pour the food into the small intestine, that part could be blocked, right? Anywhere along the GI tract can be blocked. So again, I want you guys to have that picture in your mind so that way you can kind of get an understanding of what is going on with the patient who has Crohn's, okay? Have that visual in your head. When you have that visual, it will save a lot of time in trying to memorize word by word by word by word, because you will have that understanding. Okay, there's a blockage that's going on. Okay, so I can see why the complication is going to be intestinal obstruction. I can see why they won't be able to absorb, because if there's a blockage, how can I absorb food when there's a block, right? So try to put that picture in your head of what's going on with a patient with Crohn's disease, and it will kind of better help aid you in knowing exactly what to expect. Go ahead and talk about ulcerative colitis, right? Because I've been comparing the two, and then you're like, well, you didn't talk about ulcerative colitis. Well, here it is. So ulcerative colitis is pretty much an ulcerative or inflammatory disease of the mucosa or the submucosa. Remember those 4 layers that we had, right? You have the first one was mucosa, second one is submucosa, then you have muscularis, and then you have the very last one is serosa. Okay, so these are going to affect the first 2, right? That can eventually lead to more and more bleeding, but it's going to happen in the bowels, okay, the colon and the rectum area. All right, whereas Crohn's disease happen anywhere within the GI tract, but more particularly to the right side, right, the beginning part of the actual colon, where this one begins on the left side towards the ending. And it can work its way up to the cecum area. And what's going to happen is there's a result in poor absorption, all right? And remember, the large intestines is responsible for absorbing water, and it also makes vitamin B and K, and it can work its way up around to the cecum area, all right? So of course, when you have this area that is there for absorption and you have these ulcers, eventually you have these gaps along the way, and that's what's going to cause a lack of absorption, okay? So next we have, it commonly begins in the rectum and it can spread all the way up to the cecum, like I said before. All right, so that's why I highlighted what's in purple to kind of show you the differences. So really and truly, as you can see here, there's not much differences. They are more alike than they are different, okay, because they're both almost causing the same thing. It's inflammation, right? And due to the inflammation, there is causing a lack of absorption and a lack of nutrition that's going to happen, and it leads to diarrhea and different symptoms that you would see, and is pretty much in the same field, okay? So for the most part, you'll see they kind of work similar, okay? The colon becomes very edematous and may develop bleeding lesions, all right, ulcers, and the ulcers may even lead to perforation. So again, you have that ulcer, right? So I'm just going to draw a little thing here. This is my ulcer. Remember, I have these different layers, right? These are my different layers. And let's say that ulcer gets deeper, right? So it passes the mucosa layer. Now I'm in the submucosa layer, right? And it just gets bigger and deeper, right? And of course, if it irritates it, of course you can have bleeding, right? Or it can get even deeper. But for the most part, it's mucosa or submucosa layer, all right? So just think of big ulcers like this that's in your large intestines, okay? So of course, it's going to make it harder, and you're going to have complications, right? So You have things that can get inside in this area here that just irritates this lining even more. All right? So again, or it can lead to perforation. Eventually, it goes deeper, right? Breaks away from that wall, gets deeper, and then it starts leaking out into sterile area, right? And that's when you have your problems occurring, all right? So it just kind of just say, you know what? The large intestines cannot hold anymore, and then finally there's a leakage out from the large intestines, okay? You're also going to have scar tissue that may develop and may cause the loss of elasticity, right? Because remember, I have my large intestines, right? This is my large intestines coming all the way down here, right? So if I have here, and I no longer have that elasticity to move and bring that stool, outside of my body and, discard it as waste, if I don't have that elasticity anymore, what's going to happen is I'm not going to be able to absorb as well. It's going to be very rigid, very hard, right? Very stiff. So again, you want to make sure that you prevent these things from happening. But this is ultimately what's going on with the patient who has ulcerative colitis, okay? So the scar tissue may develop and cause a loss of elasticity, okay? Which is going to cause problems with absorbing food. Again, colitis. What does the word colitis mean, right? It means multiple ulcerations, right? Diffuse inflammation and shedding of the colonic epithelial layer, which is pretty much the outer layer of the colon, all right? So that whole layer, right, is shedding, so to speak. It does happen the same as Crohn's disease, where it has remission and exacerbation, all right? So it goes and then it comes. It goes and it comes, all right? And it's almost similar to like when you have a peptic ulcer, right? You have the ulcer, it's always going to be there, but you have your moments where you can irritate it and it can cause bleeding, and then you have other times where it's fine, and then it can bleed, and then it's fine, all right? So anytime you have an ulcer, right, you're always going to have the risk of it bleeding out. Also, you have acute colitis and you have chronic colitis. So within the acute colitis, there's a few things that you're going to see that's a little bit different with the chronic. And with acute, you're going to see a result in vascular congestion. You're going to see your hemorrhage, which is the bleeding that I'm talking about, the edema, and the ulcerative of the bowels, okay? So you're going to see the ulceration of the bowels. So the bowels are all going to be, right, eroded. The mucosa is going to be damaged. The submucosa may be damaged, depending on the extent of how far deep it's gone, right? You may see the lining is completely gone from the colon, right? And then with chronic colitis, it causes muscular hypertrophy, right? You have fat deposits and fibrous tissues with bowel thickening and shortening or narrowing, okay? So again, the bowels are going to either thicken because of the scar tissue, right, that formation that it's causing, right? It may be narrow because the fact that you have the scar tissue, and so that passageway is no longer wide, it's now narrow. And then again, it can be shortened, right? Because now you have certain areas where the body's like, I can't even absorb that. So it doesn't function properly. So the bowels have been shortened, okay, of its function. Next is the clinical manifestations, which is the signs and symptoms, which is also known as your nursing assessment for ulcerative colitis. All right, so again, what I put in purple is the thing that kind of stands out that you will see more so with ulcerative colitis than you would Crohn's disease. And then the others is pretty much what they have similar with, okay, what they have in common. So we have left lower quadrant, right, which is LLQ, pain. So you're going to have left lower quadrant pain, which I said before, Crohn's disease is mostly the right, ulcerative colitis, mostly the left, okay? You're going to have a rebound tenderness on the right, left quad. So when you palpate the right, you're going to have a rebound tenderness on the right lower left quad. You may have rectal bleeding, right? You are going to have diarrhea, either 10 to 20 liquid stools for the day, and within the stool you may have blood or mucus within the stool. Now, this is what's in common with Crohn's disease, which you have the fatigue, anorexia, which as far as poor appetite, weight loss, fever, dehydration, anemia, which of course, because I have the rectal bleeding, I have the bleeding that's occurring, I am going to exhibit some types of anemia, right? I also have electrolytes imbalance, right? In particular, the hypocalcemia, which is low calcium level, and then vitamin K deficiency, because remember, the large intestine is responsible for making vitamin B and K. So you're going to have a vitamin K deficiency, all right? And then you're going to have intermittent tenesmus, which tenesmus is pretty much the feeling of wanting to pass stool and may not be able to pass stool, or the straining of passing the stool. So it's a painful strain of passing stool, or the wanting or desire to pass the stool and you're not able to pass the stool, okay? So that is what tenesmus is. And then you have extra intestinal manifestations that can occur with colitis, and you have skin lesions, eye lesions, which is also known as uveitis, joint abnormalities, which is arthritis, and then you have liver disease. So aside from all of these are some extra things that you can occur or see in a patient who does have ulcerative colitis, okay? And again, I just drew a little picture here to let you know exactly what part of the large intestine that is occurring, and it's pretty much the left side, okay? It can gradually, depending on how worse it has gotten, right? It can gradually make its way all the way up even to the cecum area, all right? So, but your typical ulcerative colitis is going to be on the left side, all right? And I keep stressing this because I'm telling you, you may see questions on this where they say the patient has pain on the left side, it's an inflammatory disease, the patient exhibits, rectal bleeding, whatever other signs and symptoms they may decide to put on there, right? And as long as you keep hearing, it's the left side, it's the left side, it's the left side. That's my ulcerative colitis, all right? So you can think of the L in the ulcerative colitis, the L, right? The L for the left side, all right? And for Crohn's disease, right, we have the R for Crohn's, and we know that is the right side, okay? So however you have to do to try to remember, try your best to remember, because this is your typical type of question that they like to ask, okay? Complications of ulcerative colitis, all right? So we have toxic megacolon, which toxic megacolon is pretty much inflammation that extends to the muscularis area. So remember, like when I was saying that you have the different layers, right? You have 4 different layers. And I'm just going to put a little drawing here. I have 4 different layers, right? I have my mucosa, my submucosa, my muscularis, and then serosa. And the damage has taken effect where it has touched down to the muscularis area, right? So muscularis, you think of muscles, right? So it got down to the muscle layer, right? Which now it lost the ability to contract. So now I'm left with colic distension, right? Because remember, the muscles are there to contract, constantly doing this. And if I have an ulcer that has made its way down to the muscularis area, right? That muscle is not able to contract and do what it's supposed to be doing. So because it's not contracting, right, it loses that contraction. So instead of it being able to move and pass the food through or pass the stool through, right, because we're talking about the colons here, so pass the stool through, right, that contraction does not happen. So it just stays like that. So eventually it goes whenever it's able to, right? And when that happens is the colon starts to get distended because there's nothing to help push and facilitate, right? So that's pretty much when you see the contraction is pushing that area. So I have my intestines here that I'm drawing, right? This is my large intestine, and I'm going to color code it so that way you can see what is going on. I have my stool that is being passed through here, right? And then I'm going to put in red, I have my ulcers. My ulcers here, right? Those are my ulcers. So this muscle is going to what? Squeeze. When that muscle squeezes, it pushes the stool through. Okay, so now I'm here. All right, it's going to relax. And now this part of the muscle is going to contract. And as it contracts, it squeezes the stool through. So now the stool is here. It's going to relax. And then this muscle is going to contract, squeezes it through. Finally, it's here, right? And then this is going to relax. So now the stool is here, and these muscles no longer can contract, so they just kind of stay there. So eventually, all the stool that's coming here eventually contracts, get in, but then it's stuck here. And eventually what happens is it gets bigger and the stool accumulates and accumulates and accumulates. And when that happens, right? All right, your body's going to try to compensate. So what's going to happen? It's going to get distended. It's going to get bigger because your body can only stretch so much, right? And these ulcers are still here because they never went away, right? It didn't go away, but this area has now gotten distended. And what's going to happen, right? Eventually, when this keeps swelling and swelling and swelling, eventually the body is going to give way and say, well, I cannot stretch anymore. It's almost as if you was to stretch a rubber band, right? You stretch that rubber band, eventually it can only stretch as much as to a certain point. Sorry, it can only stretch to a certain point. Once it has reached that point, what happens? That rubber band pops. Same thing that occurs here, right? The only difference is that it's called perforation, all right? So instead of it saying pop, it perforated, right? And all of this starts oozing out because it now has popped, right? So there's our little thing here that is popped, right? So now this part is all open. So what happens to my stool, right? My stool comes out into the sterile area of my body, right? With that, my body has went through trauma. There's going to be bleeding. You know, arteries have been disrupted, right? So I have bleeding, and I have my stool all coming outside of the large intestines, okay? So this is where you get the infection, the sepsis, right? And this is ultimately what you're trying to prevent. But this is a complication. So let's get back over here. As you can see, my next thing is perforation. So now you can kind of see exactly what's going on with a patient who has ulcerative colitis, right? And the problems that can occur depending on how deep of a layer it has destroyed, right? If it's still in the mucosa area, we're still good. Some mucosa, okay, we're getting to a point, but once we get to the muscularis area, right, there is no contraction that's going to happen there. So we're just going to get more and more distended until finally it bursts. All right. Now, here we have vascular engorgement, which is the bleeding, okay, which you can see, right, because those vessels are pressing on each other, right, as it's getting distended, they're pressing, and those vessels that press on each other, remember, they're fragile as well. So you press on those, eventually it ruptures and it bleeds. So eventually that's where you have your bleeding, okay? So I just tackled 3 things just showing you this illustration here, okay? And electrolyte imbalances. So you are going to have electrolyte imbalances. Why? Because I have these ulcers in these different areas, the body's not able to absorb all of that water properly. It's not able to make and function the way how it normally would function, right? So there is a dysfunction, a disorder that's taking place that is interrupting or disrupting the natural process of what's going on in the body or what the body should be doing, right? So the body is not able to absorb properly. It's not able to get the nutrients that it needs properly, right? You're going to see the patient's going to be losing fluid, right? Because they're having diarrhea 10, 20 times a day, right? So all these things, think about it, they're going to be dehydrated, right? The fluid, the electrolytes are going to be imbalanced because some of that electrolyte is probably going into the stool as well because it wasn't properly absorbed in the GI tract. So it goes in the toilet, right? So now you have to think about, okay, this patient is losing these electrolytes. They're losing fluid, right? They could be bleeding, right? They're not getting the nutrients that they need, right? So I have electrolyte imbalances. And all these are your complications that are going to take place in a patient who has ulcerative colitis. So I definitely want you guys to get that picture whether it's this picture or a better picture, but I want you guys to get that picture of what's going on with the patient who has ulcerative colitis and know the difference between ulcerative colitis and Crohn's disease. Crohn's disease look more like cobblestones, right? Bulging of cobblestones. Ulcerative colitis is ulcers. Ulcers, ulcer, colitis. Colitis means many ulcers, right? So just ulcers all within the lower part of the GI tract, particularly the rectum area and the left side of the colon area, okay? And for treatment of a person who has a toxic megacolon, all right, what it's going to be is you're going to see your IV fluids, which makes sense because they're losing, so I want to give them that. NG suction kit, you want to have nearby, or they may have NG to low intermittent suction, because you want to get all of this GI content out of them, right? So you don't want the body to be absorbing all of these things to then pass it through, because you want to give your stomach a rest. So you want to suck those things out, right? So NG suction. Then you also have corticosteroids. What do corticosteroids do? Anti-inflammatory medication. I have an inflammatory bowel disease. So what am I going to do? I'm going to give medications that's not going to cause inflammation, okay? So it blocks inflammation from occurring. So that's my corticosteroid. And then I have my electrolyte therapy, all right? Just in case if I've lost my calcium and I need more calcium, right? I want to make sure that I get calcium chloride, or calcium gluconate, whatever the pharmacy prescribes, or not, whatever the doctor prescribes that the pharmacy has in the house, okay? Because sometimes the doctor may order calcium chloride and all they have is calcium gluconate. Well, a pharmacy needs to know that it takes 3 calcium gluconates to equal 1 bag of calcium chloride. So, you want to make sure that you have your orders to say, hey, doc, the pharmacy doesn't have calcium chloride inside the hospital right now. What they have is the equivalent is calcium gluconate, but it takes 3 bags to equal that. So you want to just make sure that you run those things through your doctor and through the pharmacy, so that way they know that the patient needs to have the adequate electrolyte therapy, right? And then again, antibiotics, right? Because you want to prevent that infection, that sepsis from occurring. And you want to do this within 24 to 72 hours. By that time, the patient is going to be in surgery, and the surgery that they're going to have is called a total coloectomy. And remember, I just said ectomy means anything of removal, and colon, right? So removal of the colon. So if you was thinking that, you're on the right page, and kudos for you. So just remember, ectomy is anything you're going to remove, right? And you're removing the colon, all right? So if you guys got that, great. If you guys have any questions or any concerns or things that you're still confused about, just put it in the comment section below. All right, so now I'm going to go ahead and move on. So now I have the diagnostic testing for both Crohn's disease and ulcerative colitis. So when you see me have the IBD, we're talking about both, okay? So for now on, we should be talking about both. So diagnostic testing. So for both, you can do a CBC, endoscopy, colonoscopy, intestinal biopsy, a CT scan of the bowels, or a stool specimen with occult blood. So if it's positive, you will see it turn blue, and we don't have to worry about doing this test. We just make sure that we get some of the stool sample, we put it in the little sterile container, and we give it to the lab. From the lab, they will go ahead and take the dishes, smear a little bit on there, and then they'll look to see if there's any blood. They do different reagents and droplets on it. They'll see, the different color change and things like that. All right. So we don't worry about that. We just wait for the phone call when lab is on the phone saying that, hey, the patient has tested positive for occult blood, or the patient has tested negative. All right. So of course, they are going to do different tests that are going to rule out, because one that has similar stool in the blood is a GI bleed that can be from a peptic ulcer, not always IBD. So again, there's going to be multiple things to kind of rule out, so that way the patient can know. The best thing I think will be the endoscopy or colonoscopy, because again, if they do have the cobblestone appearance, you know right away that that's Crohn's disease. So I would say out of all of these diagnostic tests, the best ones is endoscopy and colonoscopy. All right. And with the CBC, you can check if the patient has anemia, because it looks at the hemoglobin levels, the hematocrit levels. It can check the white blood cell levels. So there's many different tests that can come from the labs that will show you. You can do a biopsy, see if it's cancer, because it may be colon cancer instead. So you can see if it's cancerous or so. So all these different tests can play a part in identifying the problem. So we're getting there. All right, so now we have the medical management of both of them, Crohn's disease and ulcerative colitis, okay? So we have sedative, antidiarrheal, and anti-peristaltic medications, and what they're going to do is pretty much minimize the amount of peristalsis that is going to happen, okay? So that helps to rest the inflamed bowels, and it's going to continue on with this treatment until the stool is somewhat at a normal frequency or consistency, all right? So remember we had that diarrhea going on. So remember, you want to make sure that it gets to a normal consistency and then also frequency. So remember, they was having 10 to 20 bowels, or they may have, diarrhea constantly throughout the day. So you want to narrow those numbers down, and you want to make sure that it's, a good quality stool. So the consistency is good. All right, and that's when you're going to stop with these medications. Until then, they will keep getting those medications until contraindicated or until Dr. D sees those orders. Okay. The next thing you have is aminosalicylates, which you have an example here, all right? This is your generic name, this is your trade name, and pretty much what this is used for is for mild to moderate inflammation, and what's going to happen is you're preventing or decreasing the reoccurrence in long-term maintenance regimens, all right? So this is another medication that could be one that the patient uses. Also, you have corticosteroids, which I mentioned before. These are your anti-inflammatory medications, and they are to treat the severe cases of the disease, okay? And you have different routes that you can have, which you're going to have different types of medications. So if the patient's able to, swallow or take in things by the mouth, that they're going to have prednisone. And prednisone is your typical medication that you see. And remember, with these medications, you have to taper them down, okay? You'll see them in other disease process or so that they use these medications, like your Addison's disease and things like that, or your Cushing's syndrome, or your hypothyroid medications, right? So they kind of taper them down, okay? With the next one you have is you have your IV medications, and you have hydrocortisone, which is pretty much Solu-Medrol. This will be in a hospital setting. Most of the time you'll see Solu-Medrol is the drug of choice that they use for IV medications, okay? I know that's pretty much the medication we use for IV corticosteroids, sorry. Then you have your topical and rectal. Topical just pretty much means on the skin, and rectal, that goes up in the rectum. And this is the medication that you have, and it is to treat distal colon disease, okay? Next, you have your, before I get to that, just want to let you know, the signs and symptoms will return once these medications have been stopped or they're reduced. So the doctor will have to get on a plan of exactly what he wants and how frequently he wants it to see exactly what's going on with the patient, okay? So again, these are the medications that they use. Then you have immunomodulators, and these are examples of your medication that they use. The ones that I'm familiar with is the methotrexate and the cyclosporin. And pretty much what they're going to do is they're going to alter the immune system, which pretty much ultimately they don't really know the mechanism of action, how they're working, but what they're doing is pretty much is weakening the immune response to decrease the inflammation process, okay? That's what these medications are doing, all right? So the mechanism of action, so MOA means mechanism of action, all right? So that means it's unknown. They're not too sure how it works. They just know that it's working, and this is how it's working, but they don't know exactly what cell or what receptor site is causing the change, okay? So anytime you see the mechanism of action, they're not sure, but that means they don't know exactly how it works, but it's working, okay? And those type of medications, we want to be careful. At least if I was to take medications like these that don't really know the mechanism of action, I want to be careful because you don't know how it's working. You don't know how it's going to affect your body. You get what I'm saying? So with those medications, you want to be careful. If you do take them personally, or if you take any medication personally that you don't know the mechanism of action and it's unknown, I'm not saying not to take it, but just be on guard that, sometimes you may experience signs and symptoms that are not explained, or you're not able to understand because, we don't really fully know how the drug is working. You know that it's working, but you don't know how it's working, so you don't know how it's affecting the body, all right? So you just want to be, cautious with those medications, okay? So in no way, shape, or form I'm giving medical advice at all, just telling you to be cautious if you are taking medications that you don't know the mechanism of action, okay? Also, you have newer biological therapies, and with those, they use the monoclonal antibodies. And with this is the medication here, an example, and they use this more for Crohn's disease. That's why I kind of highlighted here, so that way you know that this is specifically for Crohn's disease, not really so much ulcerative colitis. But they have made newer medications that are working better, and this is the type of therapy that they use, anti-cytokine therapy, and this one works a lot better. So again, it's the same category in the newer biological changes, but this is just a newer therapy, and pretty much what it does is it's using the monoclonal antibodies, okay? And all of this is pretty much doing the same thing of depressing the immune system, so that way it doesn't cause the inflammation response, okay? And then of course, if your patient is non-compliant, they're not taking the medication, they're not following the regimen that the doctor had prescribed for them or ordered, right? It can lead to a severe relapse. And relapse just pretty much means that when it does come back, it comes back worse, okay? So you may think that, oh, I'm fine. I've been taking the medication for 3 weeks, and all of a sudden the signs and symptoms are gone. I feel great. I'm not going to take them anymore. And you stop taking them, then you may not see the disease process for a while, but then when it does come back, it comes back a lot worse. Okay, so you just want to make sure that whatever medication you're supposed to be taking, that you're taking it consistently, and if you have any concern, that you go to see your doctor. And as a nurse, you just want to make sure that you're explaining these medications and what they're doing to the body, the side effects of these medications. And if they have any concerns, you want to make sure that you're being your patient's advocate. If they are afraid to talk to the doctor, you would kind of want to mention it to the doctor, let the patient know, say, hey, the patient is uncomfortable taking this medication. He has some concerns. Could you come in and speak with the patient about these medications, how often, and so on and so forth, okay? So you just want to make sure that you're still staying in your scope and you're doing what you're supposed to do, and you're giving the information to the patient, and that they're taking the regimen per doctor's orders, okay? And if they have any concerns, they can go ahead and ask the doctor any other questions, all right? So now we're on nursing interventions for a patient with both Crohn's and ulcerative colitis, all right? So in the acute phase, which the acute phase is when they have the, inflammation, they have all the symptoms that they're exhibiting, right? You want to maintain an MPO status, and you want to administer IV fluids, electrolytes, parenteral nutrition if they're ordered, right? And you do this because you want the abdomen and the GI tract to rest. So any other route you can give fluids and nutrients, you want to do it that way rather than the GI tract, okay? Because you want this ultimately to rest because it's already inflamed. So the next thing you want to do is restrict patients' activity to reduce intestinal activity. So you don't want them to, be doing too much. These patients want them to be on bed rest because you don't want any perforation or anything like that to occur or happen while these bowels are moving around and, are emptying out, okay? So you want to make sure that you're restricting the patient activity so they can be resting as much as possible, all right? You also want to monitor for bowel sounds and abdominal tenderness and pain, right? So you want to make sure that, when they're cramping and, they're being bothered, you want to monitor and see if it's getting worse, which side are they clinging more to, so that way you can see if is it ulcerative colitis or is it Crohn's disease, right? Then you also want to monitor stools, note the color, the consistency, and the presence if there's blood or no blood, okay? Now, if they had blood before and all of a sudden now there's no blood, that can be a sign that it's getting better. Or if they had no blood and now they have blood, it can be a sign that it's getting worse. So you just want to monitor these signs and symptoms so that way you're letting the doctor know any type of abnormal findings that you're finding while the patient is in the hospital at that moment, okay? You also want to monitor for bowel perforation, peritonitis, and hemorrhage, which we went over, different signs that you can tell if the patient is having peritonitis, right? You also, after the acute phase, so after that phase is done with, right, and the inflammation is not as much or not as often, right? They're kind of back to regular or so. You want to advance the diet from a clear liquid to a low fiber diet as tolerated, only if they can tolerate it though. So if they can't tolerate it, then you still want to keep them on the clear liquids until they're able to. All right, after that, then you want to instruct them about a diet. Let them know that they're usually going to be on a low fiber diet, right, a high protein, high calorie diet. with vitamins and iron supplements, okay? That is the biggest thing because remember, they have the malnutrition going on. So you want to make sure you're replacing it adequately. Also, you want to instruct the client about avoiding gas-forming foods like your milk products, especially if they're lactose intolerant, foods such as whole wheat, right? Whole wheat grain, and you're like, well, I thought that was good, but it has roughage. And you want to make sure that they're on a low fiber diet because you don't want too much activities going throughout the bowels, okay? Also nuts and raw fruits and vegetables because again, these are your fiber foods, right? Your fruits and vegetables, your peppers, alcohol, right? And your caffeine products. So you want to make sure that they avoid those things or keep them at a minimum, okay? But for the most part, avoid. But if you're not going to avoid because you are going to have patients that tells you, I don't care, I want this, right? Then you need to educate them and say, well, have it in moderation, very small amounts, okay? And I remember having diabetic patients and they're like, I don't care, I'm still going to want my apple juice, I'm still going to want my chocolate bar or whatever the case may be. So they know when they were able to modify their diet a little bit. So they know they were going to eat the chocolate bar or so, they were going to substitute it with a carb or something like that. So if you're going to, have a patient that's not going to want to avoid these things or, at least kind of reduce the amount, okay? So tell them to, have moderation play a factor. Also, instruct the client to avoid smoking. Remember I was saying, smoking doesn't help anybody. It really doesn't. Secondhand smoke doesn't help anyone else. And also, it just messes with your system. It messes with your vascular system. It messes with your GI tract. It just messes with your system all around, your lungs, okay? So, if you can avoid smoking altogether, great, all right? Because what it's going to do, particularly to the GI tract, is going to increase intestinal mobility. And with this, you want the intestines to be at rest. You don't want it to be active. So again, you want them to avoid. So you want to give the smoking cessation packets, let them know how to stop, if they need the nicotine patch, different things that they can do to kind of avoid smoking, okay? Also, you want to administer medications like the ones that I mentioned previously, your corticosteroids, your immunosuppressants, your antidiarrheals, and then your salicylate compounds type of medication, okay? Per doctor orders. And all of this is per doctor orders, except for the stuff that you will monitor. Monitoring is things that you assess as a nurse, okay? But if you see anything else, you want to make sure that you get an order or you confirm with the doctor that, he wants them on a low fiber diet or he wants them on, high calorie diet or so, all right? Surgical interventions. So of course, your surgery sometimes is the last option, or at least they try for it to be the last option, unless it is emergency surgery where all of the other interventions would not help and they have to do surgery. But otherwise, it's the last interventions, okay? So you have these different types of surgery. So you have a total proctolectomy with permanent ileostomy. You have a cock ileostomy with a continent ileostomy. That's the other name for it, but it's the same thing. Then you have ileoanal reservoir, and then you have ileoanal anastomosis, which is pretty much an ileorectostomy. All right, so now I'm going to go in detail letting you know exactly what these surgeries are doing, okay, or what is occurring in these surgeries. All right, so with a total proctolectomy with permanent ileostomy, the procedure is a curvature that involves the removal of the entire colon. So it's the colon, the rectum, and the anus with an anal closure. And the end of the terminal ileum forms the stoma, which is located in the right lower quadrant. So the next one we have is a cock ileostomy. Okay, and the cock ileostomy is an intra-abdominal pouch that stores the feces and is constructed from the terminal ileum. All right, and the pouch is connected to the stoma with a nipple-like valve constructed from a portion of the ileum. The stoma is flesh with the skin. All right, and the catheter is used to empty the pouch, and a small dressing or adhesive bandage is worn over the stoma between emptyings. Then you have the ileoanal reservoir, which is a creation of the ileoanal reservoir. Is a two-stage procedure that involves the incision of rectal mucosa and abdominal colectomy, construction of a reservoir to the anal canal, and a temporary loop ileostomy. All right, so the ileostomy is closed by 3 to 4 months after the capacity of the reservoir is increased and has had time to heal. And then last but not least, you have the ileoanal anastomosis, which is the ileorectal and the ileorectal does not require an ileostomy. Okay, so I know it sounds, like it needs one, but it doesn't. Okay, a 12 to 15 centimeter rectal stump is left after the colon is removed, and the small intestine is inserted into the rectal sleeve and anastomosed. Ileorectal requires a large, compliant rectum. Okay, so with all of these things here, you want to make sure that the patient is stable, that they're able to go through surgery, and eventually you want to monitor exactly what's going on with the surgery or after the surgery. Okay, you want to monitor for those things, whether you have the dressing change, make sure it's emptying, and you want to make sure that there's poop inside there. Okay, if there's no poop for days and days at a time, and you have to let the doctor know or the surgeon knows that, hey, this patient has not pooped at all, or there's no bowel sounds heard at all, because they may have to go back and fix and see exactly what's going on. Okay? Now we have the preoperative colostomy and ileostomy interventions, right? So what we're going to do is pretty much instruct the patients to eat a low-fiber diet for 1 to 2 days, once we have a doctor's order. And then we're doing this because we're getting ready to prep for surgery. All right. You also want to administer intestinal antiseptics, antibiotics to help clean out the colon area or the GI tract. Okay, so that way you're preventing infection as they're cutting to go inside, and also afterwards to help prevent infections from occurring. All right. Also, you want to administer laxatives and enemas as ordered. And I know we said before you're not going to give the laxative because you don't want to cause perforations or things like that, but this person is prepping for surgery, and of course they will do it when the patient is not as critical, and the inflammation is there, because again, you don't want to cause more damage. But if the patient is stable, they're fine, but they want to go under or the doctor wants to do the procedure, he will let you know exactly if it's safe or if it's not safe. Okay, so but in this case, you want to do a laxative because you want to clean out the colon, because they're getting ready to do surgery there. You don't want feces getting in the way, right? Because at the end of the day, that is it's unsterile, right? And it has full of bacteria, which is why you're giving the antiseptics and the antibiotics to help kind of clean all that out, right? And you don't want it to travel and get into other parts of the organs and cause sepsis, okay? So before surgery, you do want to kind of clean out that colon, give them the enema, so that way all the remaining of the stool can come out, so that way when the doctor's working, they're working on a clean colon, all right? Also, here you have your post-operative colonoscopy and ileostomy intervention. So we finished the pre-op of what we would do before surgery, and of course you clean the patient and you get them ready for surgery. You do the lab work and things like that. There are going to be low fiber for the 1 or 2 days before the surgery, and of course the day of the surgery there will probably be NPO because of risk of aspiration. Okay, and you're going to clean out the colon. So now this is what's happening after the procedure, right? So I hope I'm not losing any one of you guys. I know this is kind of long, but we're almost done. So you're going to place a petroleum gauze dressing over the stoma, okay? So now that they have the ileostomy, you have a stoma, okay? And with that, you want to make sure that it is moist as possible, okay? Also, you want to follow that up with a dry, sterile dressing. If they have a pouch or so, then you won't need to because the pouch is already there. But if they don't have a pouch, then you want to make sure that you're able to at least put a dressing or something sterile there, so that way infections or things cannot go inside, okay? Also, you want to place a pouch on the system of the stoma as soon as possible. So whenever you're able to get that pouch, you want to put that on, because when they start having their bowel movements, you don't want it getting everywhere, especially when they're laying down and it's rolling over them and things like that. You don't want that. So you want to make sure that you have your pouch ready and secure it when you're able to, after you've cleansed the area and have done the dressing changes and things like that. If it does not come with the pouch and you have to apply one on later, you want to make sure you do it as soon as possible, okay? You also want to monitor the stoma for size, unusual bleeding, and necrotic tissues, okay? So this is where it starts getting really, really important, because these are the questions that they like to ask about stoma care, all right? Providing that stoma care with a patient who has a colostomy or ileostomy. Now, I don't want you guys to get confused. An ileostomy is something similar to a colonoscopy. The only difference is where it's located, okay? So ileostomy is probably going to be more towards your right side, and your colostomy is going to be more on your left side, okay, because you're dealing more with the colons. But it doesn't matter, because sometimes you'll see ileostomy on the left side. And pretty much what the ileostomy is, this is the main thing you need to get. Ileostomy is the small intestines. Colonoscopy is the large intestine, okay? Hence the word colon. Colon is the large intestine, right? And then ileostomy, ileum is the last part of the small intestines that they will pretty much take, and they can either put it on this side and transfer it there, or you will see them have the pouch on this side. And I've seen it for both. With I had a patient where it's on this side, and I had a patient where it was on this side, and they were both called the same thing, ileostomy. So it all depends on the surgeon where he wants to take the bowels and pull it. Okay, so he can just take the small intestines and kind of stretch it over here. Okay, or you have the colostomy, the ileostomy on this side. Okay, so the difference between ileostomy and colostomy is one is the small intestine, which is the ileostomy, and you have the large intestine, which is the colonoscopy. And the only difference is the appearance of the poop. With the ileostomy, the poop is going to be very, very, very liquidy. Okay, with the colonoscopy, you will be more of a semi-solid type of consistency. Why? Because remember, the ileostomy is still a part of the small intestines, and the very beginning of the colon, right, is trying to extract all of that water. So as it's traveling up into the different parts of the colon, the stool gets drier and drier and drier and drier and drier until finally it's solid, like what we know it to be when it goes in the toilet, right? But these patients, if it's coming straight from the ileostomy, there is no time for the colon to absorb or reabsorb all of that water. So it is going to be more liquid. With the colonoscopy, you still have parts of the colon, so some of the colon is able to absorb, right? And that's how you get the semi-solid stool. So that's the only main difference between the colonoscopy and ileostomy, but the care is going to be the same, okay? It's just only where it's located, all right? But the care is the same, so don't get confused because you see two different names. It's still an ostomy. Ostomies, okay, is your artificial rectum, pretty much. Instead of having your butthole or your anus, right, your anal area, this now becomes your anal area. This is where you poop from, right? And that bag becomes your toilet. So think of it in that aspect, all right? That bag is your toilet, and these are now your rectum area, all right? So it's no longer here, it is here, all right? So you want to monitor for the stoma for size and make sure that, is it getting bigger? Because it can be that it's swelling, inflammation, different things. So just make sure that you're monitoring those things, all right? Next up is monitor for color. Color is very important. You like to ask questions about color, all right? The color changes in a stoma. So a stoma will tell you if it's thriving or if it's doing well based on the color. So you want to know the normal stoma color is pretty much a pink to a bright red. And sometimes they say beefy red, okay? So that's why I put beefy red here, and it's supposed to be like a little shiny, not too shiny, but just a little shininess to it. So it's supposed to be pink and red, pink to red, right, or beefy red and shiny, and that lets you know that there's an increased vascularity, and that means that there's good perfusion there, and that's what you want to see. You want to see a nice beefy red stoma, all right? And then you also want to know if you see a pale pink stoma, which can show indications of low hemoglobin or low hematocrit levels. And if you see a purple to black stoma, that lets you know that the circulation is being compromised, okay? And you want to call the MD right away, let them know, say, hey, the stoma is now purple and blue, or it's black, or, it's necrotic, or it's getting to, to be necrotic, so that way they can come back and fix the problem, because that means that the vessels around there is not feeding that stoma, and that stoma is going to die, and you're going to have to do the procedure again. So again, that is something that you want to let the doctor know. So again, it's very important to note the size, note the color, note the changes that's occurring with the stoma. Do the stoma care, right? You take it off, you try to clean it as much as possible using the sterile technique or aseptic technique. Again, it don't have to be too sterile, because the same way how you wipe your butt, right? If you wipe your butt, we don't use sterile cloths and things like that, right? So it's almost like this. This is your new butt, okay? Your new rectum, your new anal area. So, you'll take the normal saline or so, you wipe it down, and you'll put, change the gauze. But again, don't be too critical because your whole GI tract, right, when food goes in, eventually when it comes out is not sterile. Okay, so again, you definitely want to deal with your sterile procedure, but it is okay if certain things is not always sterile, because again, you have to think of it as if it's your butt. Okay, so you will see sometimes the doctors won't have on sterile gloves to do certain procedures or so. It's okay as long as it's the outside. Now, if you're going in, it has to be sterile. Has to be sterile because you're going in. All right. So just be aware of that when you have to cleanse and you have to clean. Know what kind of stoma that you're dealing with. Again, you just want to make sure that you are calling the doctor and you're monitoring for those changes. Now we're going to go ahead and continue on with post-operative care for colostomy interventions. All right. So you're going to assess the function of the colostomy. You want to expect that the stool is going to be liquid in the beginning stages, but then after a while, it's going to then go into its natural form. So it depends on where the colonoscopy is. That's where they're going to see the difference between the variations of the stool pattern. All right. So if it's in the ascending colon, then you should expect it to be liquid. If it's in the transverse colon, you're going to see it to be loose to a semi-form area, and then you have descending colon, which is almost close to normal. All right. You also want to monitor the pouch system for proper fit and signs of leakage. If it's leaking, then you want to do the dressing and then put a new one on. Okay. And you want to empty the pouch when it is a third of the way full, because you don't want it to get too full, because then it's going to lose the adhesiveness and it's going to drop down, and you don't want to create a mess, especially when you're educating these patients who are able to take care of themselves independently, and they're going day to day, and they're hugging people and different things like that, because these are the people you don't even know that they have the colostomy, right? Because they have on their shirts and things like that, and you can't see. So you want to let them know after it's at least a third full, you want to kind of empty it out, so that way it's not full and just hanging there. All right. Also, fecal matter should not be allowed to remain on the skin. So if you see that there's fecal matter on the skin, you want to make sure that you are cleaning that site thoroughly, because at the end of the day, there are acidic properties within the stool that once it gets on the skin continuously, it can cause excoriation and eventually break down the skin, and you will lose your skin integrity, okay, and which you do not want, because then now you're prone to having more infections and more problems, and maybe even different types of wounds because of it. So you always want to make sure you're cleaning the area and it's not exposing the skin. Okay, the stoma is fine, but not the skin. All right. You also want to administer pain medication and antibiotics to the patient, and you want to teach them about irrigating the peritoneal wound if it's present and if it's ordered. Okay. Also, you want to monitor for signs of infection. So, depending on if there's an order, you may want to irrigate the wound. Okay. Also, you want to instruct the patient to avoid foods that cause excess gas formation, okay, which we already spoke about before, which is your milk and your alcohol. You want to avoid smoking, your whole grain, your nuts, your raw foods, things like that, right? And things that's going to cause an odor, because remember, these people are not going to be able to control when they go to the bathroom anymore, right? Because they don't have that anal sphincter so that way they can hold it, because it's not coming out this way anymore, it's coming through the stomach. So it automatically kind of just pours out from time to time, and then you just have to just look or study your body or manage your body and say, hey, every time around 3 o'clock, I have a poop, or I have this, or I have that. So you'll begin to monitor and see exactly how frequent you go, so that way you can just go to the stall or the bathroom area and cleanse it out. Okay. They also come with scented odor derisers, odor eliminators and things like that, or scented, so that way it has like a almost like a, not like a perfume, but odor eliminator type of thing. So they're real up to date now with these things. So you don't have to worry about you're gonna smell or things like that if you're experiencing it, or you have to get one, or with the patient. So you want to teach these things to your patient that, you know, they do have the sensitive ones and things like that, so you don't have to worry about, you know, your self-esteem, because these people's self-esteem is going to go down. Just imagine, you know, you're able to lift up your stomach and go to the beach or go to the pool, and now, you know, you have to modify the way how you live, okay? So these patients, the main thing is their self-esteem gets shot. So you want to, you know, encourage them, support them, understand where they're coming from, and try to make different modifications, right? These people who have husbands or wives, and they have to have a temporary one, much less a permanent one, right? You know, they're not going to feel attractive to their spouse or things like that. So these are things that you're going to have to acknowledge as a nurse and be there for that patient, support them emotionally, okay? Also, you want to instruct about the patient about stomach care, right? So once they leave the hospital and they're independent, they're able to do things on their own, you want to make sure that you have taught them the things about stomach care, right? And about irrigations, because when they go home, they're going to be the ones to irrigate, you know, the stomach, you know, to make sure that it's cleansed, and just give one good cleanse out and things like that. So I'll post a link in the description box about irrigation, so you can check out that video so you know exactly what's going on with the patient who has to irrigate the stoma, okay? Also, you want to instruct the patient that, you know, they can go back to normal activities once the doctor has put in those orders in, okay? So pretty much these people live like regular people. You know, they can be just like you and me. You won't even know. You know, and I've encountered many people who have had the stomas, who has the colostomy or ileostomy. So again, you know, it's something that people live with, and you know, you just want to let them know, reassure them, and even if they don't feel sexy, you know, they actually have a place. A woman made it up. She thought of it, and she makes lingerie for women who has colostomies or ileostomies, okay? So there are still things out there that, you know, that they can do, so you can always inform your patients, you know, that it's nothing to, you know, worry about, and, you know, try to uplift their self-esteem, okay? That's the main thing you want to do as a nurse with these type of patients. Once they are well and you have done everything else, it's just kind of, you know, giving that emotional support, all right? Last but not least, we have post-operative care for the ileostomy interventions, and the main two things to note is pretty much you want to let the patient know that their normal stool is going to be liquid now. So, you know, most of the time when it's liquid, you always come to the hospital, you may say, hey, I have diarrhea. But for these people, their normal stool is going to be liquid, okay, just because it's coming from the small intestines. And it wasn't able to, you know, be absorbed from the colons, all right? And then you also want to monitor for dehydration and electrolyte imbalances. So now that they're not able to, you know, have the colons to reabsorb that water, reabsorb all of those fluids or those electrolytes and bring them back into the body, they're going out into the stool. So you want to make sure that they have the proper fluid replacement, that they're keeping hydrated, and that they are able to, you know, make sure that they watch out for electrolyte imbalances, so that they are on their iron supplements and whatever other electrolytes that they are missing, that they are, you know, able to get those supplements back. And that pretty much is it about all of the surgical interventions and things to watch out for as a nurse, and the questions that they would like to ask when you're dealing with IBD, which is your Crohn's and your ulcerative colitis. So again, if you like this video, please give it a thumbs up. Please subscribe if you haven't already. Remember to leave a comment in the comment section below if you have any questions or any concerns. And again, also remember to check out the description box for, you know, more detailed information or extra information that I did not always mention in the video here. So again, thank you for watching, and thank you for coming on this journey.